Welcome back to the Deep Dive. Our mission today is pretty specialized and very focused. We're taking on a listener request to interpret Chapter 6 of Baily and Love's 28th edition.
That's right, the chapter on tropical infections and infestations.
Exactly. And our goal here isn't to just read the textbook back to you. It's to pull out the high-yield diagnostic anchors, the surgical principles, basically the stuff that needs to stick in your mind when you're faced with one of these cases.
It's a critical chapter because, on the surface, these seem like they belong to the infectious disease physicians.
Right.
But the reality, the brutal reality, is they often land on the surgeon's doorstep as a complete catastrophe. We're talking rupture, obstructions, sepsis, things that need a knife, and fast.
And that's really the core context for this whole deep dive, isn't it? These diseases, they traditionally thrive in the tropics and equatorial regions where sanitation might be poor. But the game changer, and the book is very clear on this, is global travel. It's completely erased those geographical lines. These are no longer just tropical problems.
They're global surgical emergencies, full stop. So for you, the learner, think of this as a revision tool, a ready reckoner, something to listen to after you've done the reading just to solidify those clinical warnings.
And the challenge is huge because patients in these endemic areas, often for socioeconomic reasons, they delay seeking help.
Oh, absolutely. They don't come in with a bit of a fever. They present late. They're often toxic. And the pathology is already well established.
Which means the surgeon needs to be talking to the physician, the radiologist has to be on board, and you're definitely going to need your pathologist and microbiologist to confirm things.
It's a team sport, always.
Okay, so before we dive into the first organism, let's just nail this down. What's the single most important factor that turns these tropical diseases into global emergency presentations?
It's the sheer ease of international travel combined with, and this is the important part, a low index of suspicion in non-endemic areas.
Say more about that.
Well, a patient comes back from, say, South Asia with some vague abdominal pain. The doctor in a European hospital, their mind immediately goes to the usual suspects: appendicitis, colitis.
Gallstones.
Gallstones, exactly. But a vague fever and right upper quadrant pain in that traveler has to trigger a tropical screen. If it doesn't, you miss that crucial window for medical management.
And then they're on a fast track to a surgical rupture.
That's it. That high index of suspicion is our first big anchor.
Okay, let's apply it then. Let's start with the absolute classic, amoebiasis, caused by Entamoeba histolytica.
Let's do it. So, amoebiasis is incredibly common in the Indian subcontinent, Africa, Central, and South America. We're talking about a pathogen where, in some places, nearly half the population might be asymptomatic carriers.
Just shedding cysts continuously.
Continuously. The transmission is fecal-oral, all driven by substandard hygiene.
So how does this tiny protozoan go from the gut to needing a surgeon? What's its path of destruction?
It's a very specific journey. You ingest the cysts, they hatch into trophozoites in the small bowel, and then they set up shop in the colon.
And in the colon, what do they do?
Their first move is to invade the submucosa. They release enzymes that literally dissolve the tissue, creating these classic pathognomonic flask-shaped ulcers.
Well, acid, okay.
And if that infection becomes chronic, the inflammation can create a granulomatous mass. We call that an amoeboma, and it's usually found in the cecum.
But the real surgical danger, the emergency, that comes when it leaves the bowel, right?
Exactly. The trophozoites break through the colon wall, they get into the portal circulation, and they're carried straight to the liver.
And they get trapped there.
They get trapped in the portal triads. And here's the key mechanism. They release these incredibly potent proteolytic enzymes. This isn't your standard bacterial pus, it's liquefactive necrosis. They just melt the liver tissue, and that creates the abscess.
And the location of that abscess in the liver is super important for diagnosis.
It's critical. The book is very specific. 80% of these abscesses are in the right lobe.
80%. And why there?
It's a great memory anchor, actually. It's all about anatomy and blood flow. The blood from the superior mesenteric vein, which drains the colon, runs a much straighter course into the larger right portal vein.
So it's just a more direct path.
A more direct path, so the trophozoites get trapped there more easily, and they often track high up against the diaphragm.
Which explains why patients might come in with, like, lung symptoms.
Right. A non-productive cough, hiccups, or that classic right shoulder tip pain from diaphragmatic irritation. It can be a real clinical red herring.
Okay, and now for the sensory anchor. What's inside the abscess? What does it look like?
It is unmistakable. The fluid is chocolate-colored, thick, odorless, and it's classically described as being like anchovy sauce.
Anchovy sauce, that's vivid.
It is, and a crucial point for management. This fluid is usually sterile. It's not pus in the traditional sense, it's just necrotic liver and blood. It only gets secondarily infected in maybe 10% of cases.
So let's talk about the emergency.
Rupture. The typical patient is, a young adult male, often with weeks of just feeling unwell, malaise, low-grade fever. Then they get this acute, severe right upper quadrant pain.
And if it ruptures?
If it's high on the dome, it can rupture into the right pleural space. But the real terror is a left lobe abscess.
Why the left lobe specifically?
Anatomy. It's right next to the pericardium. A rupture there goes straight into the pericardial cavity. And that's immediate, life-threatening cardiac tamponade.
Wow. Okay. Before we get to treatment, let's go back to the gut. The ameboma. This is a huge diagnostic challenge.
It's one of the highest stakes differentials in the entire chapter.
Let's run a quick case then. A 55-year-old patient just back from a trip to an endemic area. He feels generally unwell, has a fever, and you can feel a mass in his right iliac fossa. He's anemic and reports a couple of months of intermittent, blood-stained mucoid diarrhea.
Okay.
So you're thinking ameboma. But you have to be thinking Kegel cancer. What's the one clinical clue that pushes you more towards ameboma?
The classic teaching is the history of blood-stained mucoid diarrhea. Right-sided colon cancers usually don't mess with bowel habit like that. They just cause occult bleeding. That mucoid discharge is classic for amoebic colitis.
But you can't rely on that, can you?
You absolutely cannot. The source material is adamant on this. The imaging can look identical, even the apple core lesion you see in cancer. And chronic inflammation can always lead to malignancy.
So what's the bottom line?
Colonoscopy and biopsy are mandatory. You treat for the ameboma first with medication, but if that mass doesn't completely disappear in, say, 3 to 4 weeks, you have to surgically resect it to rule out a coexisting cancer.
So the two can even exist at the same time?
They can, and that's the trap.
Okay, what about diagnostics for the abscess itself?
Serology like an ELISA test is really useful, but with a big caveat.
Which is?
In a non-endemic area, in a traveler, a positive test is huge. It confirms exposure. But in an endemic area, where half the people might be walking around with positive antibodies, its value drops right off.
So you need imaging?
You need imaging. Ultrasound is usually first. You're looking for a hypoechoic, fluid-filled lesion with fuzzy borders. CT then confirms the size and location.
Let's talk treatment. The book mentions a dual-phase approach. Why do you need two different drugs? Why isn't metronidazole enough?
Because metronidazole is a fantastic systemic drug. It kills the invading trophozoates in the liver and in the bowel wall.
Yeah.
But it's not well concentrated inside the bowel lumen. It doesn't touch the tough little cysts or the trophozoates that are just living freely in there.
So it kills the invaders, but not the reservoir.
Perfectly put. So after you finish the metronidazole, you must follow up with a luminal amubicide like diloxanide furoate to clear the gut. If you don't, the patient will almost certainly relapse.
That distinction is a brilliant clinical anchor. So when does the surgeon actually step in to drain the abscess?
Medical management is always first. We only drain if we see signs of impending rupture, like a really thin wall on ultrasound, or if the patient just isn't getting better after 48 to 72 hours of IV antibiotics.
Is there any absolute indication for draining early?
1. Any left lobe abscess.
Because of that risk of pericardial rupture.
The risk is just too high. It's a prophylactic move. Otherwise, surgery is for the complications. Clean out the chest or abdomen after a rupture, or taking out that ameboma that won't go away.
Okay, I think that really nails down amoebiasis. Let's do a quick recap.
Key takeaways. Entamoeba histolytica hits the right lobe 80% of the time, makes anchovy sauce pus. Always think ameboma for a right iliac fossa mass in a traveler, but you must rule out cancer. And treatment needs 2 drugs. 1 systemic, 1 luminal.
Excellent. Let's move from a protozoan to something much bigger. Helminthic infections. The worms. I'll start us off with Ascariasis, the common roundworm. We're talking about Ascaris lumbricoides. The numbers are just staggering. It affects, what, a quarter of the world's population?
It's unbelievable. Thrives in hot, humid places with poor sanitation, and its sheer size is what makes it a surgical problem. An adult worm can be 45 centimeters long.
That's huge. And the life cycle is this incredible journey. The book calls it the Grand Tour life cycle.
It really is a tour. You swallow the eggs, larvae hatch in the jejunum, and then they're off. Portal system, liver, general circulation, and then the lungs.
They mature in the lungs.
They mature in the lungs, causing an eosinophilic pneumonitis called Loeffler's syndrome. Then they get coughed up, swallowed again, and finally become adults back in the small intestine.
And once they're adults, they cause malnutrition, pain, and then they start to wander.
And the wandering is the surgical nightmare. They can swim upstream right into the bile duct, causing cholangitis or jaundice. They can block the pancreatic duct and cause acute pancreatitis.
But the defining surgical emergency, especially in children, is what the book calls the spaghetti obstruction.
It's a horrifying image, but it's accurate. An acute intestinal obstruction from a massive, tangled bolus of worms, usually stuck in the terminal ileum.
And that bolus can actually cause the bowel to perforate.
It can. The pressure from the worms can cause necrosis of the bowel wall. It's a true emergency.
So for diagnosis, you're looking for high eosinophils, maybe ova in the stool. But what about imaging? How do you see this spaghetti?
On a plain X-ray, you might just see signs of obstruction, but if you look really closely, you can sometimes see the faint outlines of the worms themselves.
Revolinier structures.
Exactly. But the really classic sign is on a barium study. The barium can actually get inside the worm's own digestive tracts, so you see these white lines lying freely inside the bowel lumen. For biliary migration, ultrasound or MRCP is great. You can literally see the worm wriggling in the bile duct.
Okay, now for the treatment paradox. The poison spaghetti problem.
This is such a critical concept. The primary treatment is anthelminthic drugs, obviously. But, and this is a huge but, if you give those drugs to someone with a massive worm bolus,
It makes things worse.
it can precipitate or worsen the obstruction. The drugs cause the worms to die and stiffen rapidly, turning a soft, malleable bolus into a solid, concrete-like mass.
So if a child comes in already obstructed from worms, you can't just give them the drugs.
You can't. You have to start with a conservative trial. For fluids, NG suction, and this is a key detail from the book, hypertonic saline enemas.
Why hypertonic saline specifically?
It does two things. First, it irritates the bowel, increasing motility. Second, it helps draw fluid into the bowel. The combination of more fluid and more movement can help untangle the worm bolus and push it through the ileocecal valve naturally.
That's a fantastic clinical pearl. And if that fails, then it's surgery.
And the principle is to do as little as possible. The first maneuver is always to try and gently milk the bolus of worms through the valve into the colon.
Without opening the bowel.
Without opening the bowel if you can. If the bowel is compromised or there's a perforation, then you have to resect.
And what's the rule about doing an anastomosis? About sewing the bowel back together in that situation?
The risk of that anastomosis leaking is incredibly high. The bowel is inflamed, infected, and there are still worms around. So the safest option is often to resect the bad segment and bring out a proximal ileostomy and a mucus fistula.
A staged procedure.
Exactly. You come back months later, once the patient is healthy and worm-free, and you put them back together.
A very sober reminder of the risks. Okay, let's switch to another helminth, one that's far more subtle but potentially more deadly in the long run. Asiatic cholangiohepatitis. You called this the silent assassin.
It is because of its main complication. This is caused by liver flukes like Clonorchis sinensis. You get it from eating raw or improperly cooked freshwater fish, mainly in Southeast Asia.
So the pathology is all about the worm living inside the biliary tree for years.
For decades sometimes. It lives in the small intrahepatic bile ducts, and its presence causes this constant low-grade inflammation and fibrosis.
And the end result of that chronic inflammation.
A massively increased risk of cholangiocarcinoma, cancer of the bile ducts. That's the killer.
What are the symptoms when it's not silent?
Classic biliary obstruction. Fever, rigors from cholangitis, jaundice, itching. The worms and their eggs also act as a nidus for stone formation, so these patients get recurrent bouts of infection from stones made of sludge and parasite debris.
How does imaging help you distinguish this from, say, regular gallstone disease?
There's a very specific pattern. On an ultrasound or CT, you see this uniform dilatation of the small peripheral intrahepatic ducts, but the main common bile duct might look completely normal.
So the problem is way out in the liver periphery.
Exactly. That peripheral dilatation is the key imaging anchor.
Treatment is medical to kill the fluke, but surgery is needed for the stones and the obstruction.
Right. Praziquantel and albendazole can cure it early. Surgically, you do a cholecystectomy and explore the common bile duct, and the book emphasizes you have to do repeated washouts to get all the sludge and stones out.
And after you've cleared the duct, you often need a biliary enteric bypass. You mentioned a Roux-en-Y configuration is preferred. Why?
It's all about preventing reflux. The Roux-en-Y choledochojejunectomy uses a long limb of intestine to drain the bile. This long limb acts as a one-way valve, preventing gut contents from flowing back up into the damaged biliary system.
Which would just cause more infections and more stones.
Exactly. And in some centers, for patients with really recurrent disease, they'll do something called an access loop.
What's that?
They bring that roux limb right up to the skin, creating a small stoma. This gives interventional radiologists easy, permanent access to the biliary tree for future procedures without the patient needing another huge operation.
That's incredible foresight. And the public health message here
Is screening. Because of that cholangiocarcinoma risk, migrants from endemic areas should be offered regular liver ultrasounds. If you can find and treat the fluke early, you can eliminate that lifetime cancer risk.
Let's do a quick recap for the worms.
Sure. Ascariasis is the great migrator. Causes the spaghetti obstruction. You manage it conservatively first with hypertonic enemas. Clonorchis is the silent assassin. It drives cholangiocarcinoma risk, and you manage it surgically with a reflux-preventing Roux-en-Y bypass.
Perfect. Now let's move into the chronic infestations, the ones known for causing long-term disability, starting with filariasis.
Filariasis. Caused by Wuchereria bancrofti, spread by mosquitoes. And the global impact is just enormous. The WHO says it's the second most common cause of long-term disability worldwide, right after leprosy.
So after the mosquito bite, the pathology just slowly unfolds over years.
Very slowly. The adult worms live in the lymphatic system. It can take almost a year for them to even mature. The acute phase is these episodes of fever and painful lymphangitis, but the real damage is chronic.
And it's all about lymphatic obstruction.
Pure progressive lymphatic obstruction. Years of inflammation cause the lymphatic channels to scar up and fibrose. This leads to this massive non-pitting edema, which is elephantiasis.
And the skin changes.
The skin becomes thick and pebbled because the superficial lymphatics are blocked too. It's described as peau d'orange, like the skin of an orange.
And it's not just the legs, is it?
No, scrotal and penile elephantiasis are very common, and hydrocele is a classic finding. If the abdominal lymphatics are blocked, you can get things like chylerial lymph in the urine.
Diagnosis is clinical in advanced cases, but for early detection, you need that nocturnal peripheral blood smear.
That's right. The microphilia, the immature forms, only appear in the peripheral blood at night. Medical treatment with diethylcarbamazine works, but only in the very early stages before all that fibrotic obstruction sets in.
So once you have established elephantiasis, the surgeon's role is pretty limited.
Very limited. We can fix the hydrocellular, sure. But the limb reduction operations, they've historically had really poor results. You're mostly managing the consequences, not curing the underlying fibrosis.
Okay, let's switch gears to hydatid disease, the cystic menace. This one is all about its structure.
It is. This is Echinococcus granulosus, the dog tapeworm. The key epidemiology link is that dogs are the definitive host. Humans and sheep are intermediate hosts. So you can see this even in non-endemic countries, like in sheep farming communities.
A farmer with a weird liver cyst should make you think of this.
Immediately. And the cyst itself is like a fortress. You have to know the layers.
What are they?
The outside layer is the paracyst. That's just compressed host tissue. Then you have the non-infective hyaline ectocyst. And the critical one is the innermost layer, the endocyst, or the germinal membrane.
That's where the viable parasites are.
That's where the daughter cysts and the scolices are. Spilling the contents of that layer is the absolute nightmare scenario.
The book stresses the importance of classifying these cysts before you touch them.
The WHO IWGE classification, yes, it's essential. It tells you if a cyst is active, transitional, or inactive and calcified. You might just watch an inactive cyst, but an active one needs a very carefully planned intervention.
Most common sites are liver, then lung, and the emergency is rupture.
Anaphylactic shock is the big one. The release of all that parasitic antigen triggers a massive allergic reaction. And if a lung cyst ruptures into a bronchus, the patient can literally cough up white material containing the scolices.
And on imaging, for a pulmonary cyst, there are two unforgettable signs.
The must-know signs. First is the meniscus or crescent sign. That's a little sliver of air between the paracyst and the inner layers. It means rupture is imminent.
And after it ruptures,
you get the water lily sign. The inner membrane collapses and floats on the remaining fluid inside the cyst cavity. It looks just like a lily pad.
Unforgettable. So for treatment, it's not always open surgery anymore.
No, the minimal access approach is a great mnemonic. Puncture, aspiration of the fluid. Injection of a scolicidal agent like hypertonic saline to kill that germinal layer, and then reaspiration of everything.
And the single overriding surgical rule during any procedure for hydatid disease.
Do not spill the contents. It's the #1 rule. You risk anaphylaxis right there on the table, and you risk seeding the entire peritoneal or pleural cavity with new cysts.
Let's do a quick recap for this section.
Filariasis causes massive, irreversible edema elephantiasis, and surgery is mostly for complications like hydrocele. Hydatid disease needs WHO staging. Its rupture gives you the crescent and water lily signs, and the management is the pear strategy, with an absolute obsession about not spilling the contents.
Perfect. Let's move on. We're now tackling bacterial, fungal, and viral conditions, starting with one that has a huge historical weight. Leprosy or Hansen's disease.
Right, caused by Mycobacterium leprae. And you're right to mention the historical stigma. The source material really emphasizes the need for public education to combat that.
The pathology itself has a fascinating and simple memory anchor.
The cold affinity anchor. The bacillus loves the colder parts of the body.
Why is that so important clinically?
It explains the entire distribution of the disease. It thrives at cooler temperatures, so it settles in the nasal mucosa, the skin of the face and ears, and the superficial nerves of the hands and feet.
And the disease presents on a spectrum, depending on the person's immune response.
Exactly. On one end, you have lepromatous leprosy. That's a poor immune response. The bacteria are everywhere. You get these extensive skin nodules or lepromas, leading to that classic disfiguring leonine facies.
The lion-like face.
Yes. On the other end is tuberculoid leprosy. That's a strong immune response. The bacteria are scarce, the damage is localized, and you get these well-defined and critically anesthetic skin patches.
And the real surgical devastation comes from that anesthesia, from the nerve damage.
It's all about the secondary effects. The hands and feet become numb, so the patient gets repeated injuries, burns, cuts, pressure sores that they don't even feel. This leads to chronic ulcers, infection, and eventually the body just resorbs the bone, leading to autoamputation.
And you see these very specific deformities.
You do. Claw hands from ulnar and median nerve damage, foot drop from lateral popliteal nerve damage, plus you can see loss of eyebrows, collapse of the nasal bridge. It's a devastating disease.
So after the patient gets their multi-drug therapy for a year, where does the surgeon come in?
The surgeon's role is all about functional restoration. It's highly specialized work. And the core technique is the tendon transfer.
Explain how that works for, say, a claw hand.
The principle is brilliant. You take a tendon from a healthy working muscle, say one of the wrist flexors, and you surgically reroute it to do the job of the paralyzed intrinsic muscles of the hand.
So you're borrowing a functioning motor to power a system that's lost its engine.
That's a perfect way to put it. You can restore pinch grip, you can restore grasp. For foot drop, you can transfer the tibialis posterior tendon to the top of the foot to lift it up. It's life-changing reconstructive surgery.
And for the ulcers?
Careful debridement and then absolute protection, usually in a plaster cast, to completely offload the pressure from the insensate foot so it can actually heal.
Let's move to mycetoma, a disease of a specific geographical belt.
Yes, the mycetoma belt. This is a chronic, destructive granulomatous disease. It can be caused by fungi mycetoma or bacteria actinomycetoma.
And the route of infection is key.
It's inoculation from the soil, usually an unrecognized thorn prick in someone who walks barefoot. So the foot is the most common site, about 70% of cases. And it's important to note it's not contagious.
It's notoriously late presenting. Why is that?
Because it's initially painless, and this leads to massive destruction before the patient seeks help. The clinical presentation is a pathognomonic triad.
The painless destructive triad.
1, a painless subcutaneous mass. 2, multiple sinuses that form over the mass. And 3, a seropurulent discharge that contains visible colored grains. The color tells you what the likely organism is.
The book mentions a critical diagnostic challenge here.
It does. The superficial appearance is very deceptive. The disease tracks deep along fascial planes. And for that reason, local anesthesia for a biopsy is absolutely contraindicated.
Why?
Because the needle track or the incision can seed the infection much deeper, accelerating the spread.
So how do you map out that deep spread?
MRI is the best. On a plain X-ray, the bone can look terrifying, sometimes mimicking an osteosarcoma with a sunray appearance.
But MRI has a specific sign.
A highly specific sign, the dot and circle sign. It's the high-signal granulomas surrounded by a low-intensity fibrous matrix. It's pathognomonic.
And management is a long haul.
Very long. Combined medical and surgical. You often give months of medical therapy first to try and shrink it and make surgery easier, but wide local excision is the goal. Sadly, for advanced cases, amputation is needed in up to a quarter of patients, and the recurrence rate is very high.
Finally, in this section, poliomyelitis, a disease we hope is on its way out, but the surgeon still has a role.
A delayed but important role. Polio is the enterovirus that attacks the anterior horn cells, causing a lower motor neuron paralysis.
And the surgeon's role is not acute.
Not at all. We have to wait. Muscle function can continue to improve for up to 2 years, and patients develop these incredible compensatory or trick movements. You have to wait until the paralysis is completely static before you even think about surgery.
And the goals of that surgery?
Rehabilitation. It's tendon transfers, just like in leprosy, to restore function, and arthrodesis, or joint fusion, to stabilize flail joints, especially in the foot and ankle, to create a stable platform for walking.
Okay, we've covered a lot. Let's move to our next section, focusing on key gastrointestinal and organ-specific bacterial infections. Let's start with tuberculosis.
TB is hugely relevant again because of travel and HIV. We'll focus on 2 key surgical presentations in the neck and in the gut.
Let's start with the neck, cervical lymphadenitis. The key sign here is the cold abscess.
Right. A young patient, often recently arrived from an endemic area, with systemic symptoms like night sweats. And in the neck, you find these matted nodes. Then a fluctuant painless mass develops. That's the cold abscess, no heat, no redness, just underlying casus necrosis.
And if it's left untreated, it can form that classic surgical sign.
The collar stud abscess. That's when the abscess, which starts deep, bursts through the deep fascia, but gets trapped under the skin. It forms this bilocular 2-part mass. Eventually, it can burst through the skin and form a chronic sinus.
And treatment is primarily medical. Now, intestinal TB. The book describes 2 main types.
Yes, and it's all about the host's immune response. The ulcerative type is when the host response is weak. You get these transverse ulcers in the terminal ileum that heal with fibrosis, leading to multiple short strictures and obstruction.
Any other type?
Is the hyperplastic type. This is a strong host response. You get this massive inflammatory thickening, usually in the ileocecal area, that forms a mass. It can look exactly like Crohn's disease or a cancer.
So how do you tell it apart on imaging?
Barium studies are key. You'll see the strictures, but the anchor sign is what the fibrosis does to the cecum. It pulls it upwards and medially, creating a classic high subhepatic cecum. That, plus maybe some signs of TB on a chest x-ray, points you to the right diagnosis.
The emergency presentation is usually obstruction. How do we approach that surgically in a patient who's already sick and malnourished?
Electively, after medical treatment, we try to be conservative. We'll do a strictureplasty to widen a single stricture, but in an emergency, the rules change.
Yes.
The patient is often profoundly unwell. A primary anastomosis sewing the bowel back together is just too risky. It will leak.
So you do a staged procedure again.
It's the only safe way. You resect the disease segment, you bring out a proximal ileostomy to divert the fecal stream, and you create a distal mucus fistula. Then you come back months later after they've had their TB treatment, and you reconnect everything.
A life-saving, cautious approach. Okay, next up, tropical chronic pancreatitis. A really interesting non-alcoholic form of the disease.
Yeah, this affects young people under 40 from poor areas, particularly southern India. And you're right to stress, alcohol is not a factor.
The etiology is fascinating, the cyanide diet anchor.
It is. The theory is that it's linked to a diet high in cassava, or tapioca, which is a cheap staple food.
And cassava contains cyanide.
It contains cyanide derivatives, and in someone who is malnourished and lacks certain amino acids, the body can't detoxify that cyanide. This leads to chronic toxicity that just destroys the pancreas.
And what does that destroyed pancreas look like?
It's fibrotic and hard, with hugely dilated ducts that are filled with large, branched calcium carbonate stones. They call it fibrocalculous pancreatic diabetes. And it carries a very high long-term risk of pancreatic cancer.
Diagnosis is the clinical triad of abdominal pain, malnutrition, and diabetes. What's the imaging anchor?
The plain abdominal X-ray. It's often all you need. It shows this dense, widespread calcification throughout the pancreas. You just don't see that in other types of pancreatitis in this age group.
And surgery is really just for pain relief.
Only for intractable pain. The main operation is to clear the stones from the duct and then do a drainage procedure, a side-to-side pancreaticogynostomy, to allow the pancreatic juice to drain freely. You try to avoid resection in these young patients.
Finally, typhoid perforation. A sudden septic disaster.
Right, Salmonella typhi, a disease of poor sanitation. It's a medical illness until this complication hit.
And the damage is very localized.
It has a real affinity for the lymphoid tissue in the gut, specifically the Peyer's patches in terminal ileum. It causes them to become hyperplastic, then necrotic, and then they ulcerate right through the bowel wall.
And the timing of that perforation is critical.
It typically happens late, in the second or third week of the illness, when the patient is already weak and debilitated.
So the clinical warning is absolute.
It is. Any patient being treated for typhoid who suddenly gets worse, who develops severe generalized abdominal pain, you have to assume they've perforated until you've proven otherwise.
Time is tissue here.
Absolutely. The shorter the time from diagnosis of perforation to the operating room, the better the outcome.
So what's the goal in the OR?
The goal is minimal life-saving intervention. You're there to control sepsis, not to do a fancy operation. Options are simple closure, maybe a wedge resection, or in the sickest patients, just exteriorizing the perforated segment as an ileostomy.
And there's a crucial step after you fix the first hole.
You have to run the bowel. You must look for other Peyer's patches that look like they're about to perforate and deal with them at the same time.
And you'd never close the abdominal wound primarily.
Almost never. The contamination is so severe, you leave the wound open for a delayed closure a few days later.
That completes our deep dive through the pathologies. This has been a huge amount of information. Let's try and consolidate with a final high-yield checklist of the anchors we've discussed.
Okay, rapid fire. Amoebiasis. Anchovy sauce pus, 80% right lobe.
Ascariasis, the spaghetti obstruction, and the danger of giving antihelminthics too early.
Asiatic cholangiohepatitis. The cholangiocarcinoma risk.
Hydatid disease.
Yeah.
The water lily sign and the pear method.
Leprosy. The cold-loving bacillus and the secondary functional deformities that need tendon transfers.
Mycetoma, the panless triad, and the MRI dot and circle sign.
TB, the collar stud abscess in the neck, the high subhepatic cacum in the gut.
And typhoid, perforation risk in the second or third week.
That's a good summary. I think it highlights how these diseases are really a stark reminder of how things like hygiene, diet, and poverty directly create these incredibly complex surgical emergencies.
It brings it all together. And that context, that epidemiological awareness, leads us to our final provocative thought for you to think about. If global travel is making the term tropical infections kind of obsolete, and climate change is expanding the range of vectors like mosquitoes, how is the very definition of tropical surgery going to change in the next 20 years? And how prepared does the global surgical community need to be for these diseases to stop being exotic and start being truly ubiquitous?
That's a huge question about the future of surgical training.
It is. A critical thought for all learners in the field. That's it for this deep dive. Thank you for joining us.